is Dr. John Dimer talking to you again. I'm doing a series of lectures on the treatment of metabolic bone disease, specifically osteoporosis, also osteopenia. And we've already talked about the different diagnostic modalities that you can use. Just to recap that: FRAX scoring, DEXA TBS scoring, radiographic analysis, and also surrogate Hounsfield units off the CT scans that we all get as a way to diagnose this disease. And we're going to move a little bit differently into treatment and give you a little bit of review of the literature on how it affects operative treatment and why we know it's so important, because we have unfortunately in a lot of ways been blessed with a lot of people that have very poor bone quality, but yet they require surgery on their spine or a broken hip or things along that line, where their quality of life is so poor due to often neurological problems or bone instability that we're somewhat forced to actually operate on them. So we're going to talk a little bit about some of the testing, some of the tests that we've done, and some of the papers we've written about how we really know how important this is, particularly from the standpoint of getting spontaneous compression fractures, which I'm sure all of you see in your offices if you're a primary care provider all the time. It's just simply one of those common things we see coming through the emergency room referred back to us. But the treatment, I've always told the patients, is not surgery. The treatment, since it's metabolic bone disease, is medical. And we now have marvelous medications that have come out over the last 15 to 20 years, and more recently 5-6 years ago, that we actually can reverse the years of development of poor bone quality and stabilize the spine in such a fashion that we can actually dramatically cut down on vertebral and hip fractures. And this is a good thing. And of course, it comes with a high cost, which inevitably a lot of these breakthroughs do, but it's certainly worthwhile for all of you to screen for these patients, because if and when they do need, for example, spine surgery for spinal stenosis, we'll be able to treat them more quickly and effectively if their bone health is in good condition. If it's in very poor condition, it's going to delay that treatment, because we often will have to pre-treat those patients for many, many months. And so the whole purpose of all these lectures we're going to be doing is both for CME and also to just kind of highlight the importance of bone health and how it's a chronic condition that we treat, just like high blood pressure or diabetes or other things, and the fact that we have available treatment modalities that are very effective. Now, treating bone sometimes is a little less than satisfying. It's almost like watching paint dry on the wall, because it's a very slow process, because your skeleton remodels and repairs very slowly, measured in many, many months and years, not just a quick drop in glucose because we give somebody an insulin shot, or a quick drop in their blood pressure when we adjust their blood pressure medication. It takes time and effort, but we can do it. And so we're trying to educate all the primary care internal medicine doctors, family practitioners, our nurse practitioners, our PAs, and anybody else that's interested in treating this, to really kind of be a little bit like Sherlock Holmes that we talk about a lot in these lectures, and find out why they got the fracture, and effectively treat it and institute treatment as quick as you can. And it's really important for us, because often we have to send the patients back, because a lot of times the insurance companies won't pay for somebody that's BMI is over 40 now for any sort of surgery unless it's an emergency. And so we have potentially marvelous new drugs for that. And the same thing is true with bone density. We're going to have to delay surgery, but we also have some breakthrough drugs that we call anabolic medications, that can actually build bone mass. When, as we mentioned in our last lecture about diagnosis, is after the age of 30, you lose bone density for the rest of your life. And you have to slow that down by exercise and weight reduction, avoiding smoking and drinking. These are things we're going to hit in every single talk we give you to start in the preamble, because they're the first thing you can do that are simple and easy in many aspects and don't require expensive medications. So now we're going to move on to treatment of osteoporosis. And we're going to start a little bit because of what we just talked about, osteoporosis' effect on operative treatment. What we have found in our spine patients, when we go back and look at large series of them, the first thing we started getting curious about a decade ago was preoperative vitamin D deficiency in spine fusion. So Stoker, Ravanda, and some other people looked at this, and not unsurprisingly, considering we were having so many failures of instrumentation pulling out a soft bone, there's a very high incidence of vitamin D deficiency in preoperative spine patients. So as a prelude to surgery, we always check for vitamin D levels because that's one of the things that's necessary for good bone health, to have adequate bone metabolism. The incidence of osteoporosis in elective spine surgery was also looked at by multiple surgeons. And we found that really, amazingly, 45 to 60% of the patients have poor bone health. In other words, they already have osteopenia or osteoporosis. So if we know there's a pretty high chance that if we put a screw into soft bone, it's going to pull out, and effectively they're not going to get a good fusion, then we're going to have to treat this preoperatively in order to, again, delay treatment. So here's another study that shows not only vitamin D levels that are low cause problems, they cause osteoporosis and osteopenia, but as a consequence of these, about 45 to 60% will have bad bone when they see us. Now, Kim looked at the postoperative vitamin D status, and what he found was that they had pretty poor outcomes. If their vitamin D levels were low, their outcomes were worse. In other words, the success of surgery was less. So again, just another factor that for whatever reason, whether it's the fact they're not fusing, they've got more complications, or whatever, we do know that the outcome measures that our metrics by not only us, but also CMS and the federal government look at these as to how you're doing as far as your surgery success, we know they do more poorly. So Ravanda looked at these, okay, and he looked at vitamin D and outcome in spine fusions in patients with a very simple degenerative spondylolisthesis, a single level fusion that's widely done and is very successful if they achieve a solid fusion. And what he found was that vitamin D deficiency was quite common in these patients, as obesity was quite common, diabetes was quite common, and almost none of them were on oral D3. And they were in populations that were at risk, okay? And basically, these patients were shown to have a much worse outcome because of the vitamin D deficiency. And really what you found was time to fusion was dependent on vitamin D3 levels. In other words, if they were deficient, whatever it had to do with the healing of the bone, and we know vitamin D is critical to that, they didn't heal up as quickly, and the odds ratio decreased the risk if we gave them, or decreased rather, if we gave them vitamin D by a lot. And so this is why we start our patients as quickly as we can on vitamin D to get those levels up throughout surgery. So when you look at the outcomes of this on the graph to the right, you'll see that if the vitamin D was less than minus 20 nanograms per deciliter, it took 12 months to fuse. While if it was over 30, it took 6 months to fuse, half as long. So this is why we all of a sudden said, well, we ought to pay attention to this. In our center, we've been giving vitamin D, as far as I can remember, for at least a decade, most of us, on all our patients and checking these levels in an effort to boost our fusion rates. Here's the proof to show you why we've done it, in that it will dramatically improve our surgical outcomes. And these are your patients too. They're going to improve the chance of them showing back up into your office with problems too. So this is why vitamin D is so important. And you can see that here. Now, Bazurki basically looked at bone status and fusion outcomes. This was done out of Mayo's. And what he found was that half the people had normal bone, about a third were osteopenic, and 10% were frankly osteoporotic. And the osteoporotic complications following surgery included failure to fuse, a pseudoarthrosis, kyphosis because they developed fractures above the rigid fuse segments, fractures through the fusion, and of course, ultimately, the screws get loose and the rods break, okay? And then they show back up, and then you just moan and groan in our office and say, oh my gosh. And about half the time they'll be symptomatic and you have to address the fact they have not fused successfully. And what's even more remarkable is the fact that when you had really low, you had osteoporosis in these patients, you can see here that the osteoporotic related complications were 50% in patients that had osteoporosis versus 20. So almost a twofold increase. And the non-union went from 18% for normal and osteopenic, which were pretty close, and other studies have shown that particular feature, to almost 50% of them did not heal. Very major findings as far as why we. So then we started looking at, the first thing we had were the bisphosphonates, okay? Unfortunately, I can't give you the trade name for them because even though it's probably important, but you'll have to look it up. There's multiple ones, several available that we'll talk about. But here's a whole bunch of authors, mainly in Japan, where they have just absolutely epidemic osteoporosis there. And so they've been kind of a training area for a lot of these medications we're going to talk about. But all these guys had randomly, RCT studies, okay, randomly controlled studies, and they looked at a whole bunch of clinical results in bisphosphonate studies. And they generally were favorable as far as causing bone healing better, because for whatever reason they allowed the fusions to set up more. And as a consequence of that, the patients did better and had better clinical outcomes, and they had less complications. So treating osteoporosis before surgery and during surgery makes sense, okay? And that's what we do. And the next drug to come along about 15, 16 years ago now was denosumab, okay? Not only does it work for bone, but it also works on giant cell tumors and shuts them down because it specifically targets osteoclasts, which reabsorb bone and neutralizes them. So the result is you get less reabsorption of bone and you get a net loss of, your bone doesn't decrease as much. And actually out of 10 years, it's actually been shown not only to decrease bone loss, but it is slightly anabolic and not just catabolic. It actually will increase bone, and we'll talk about that more. But it's a monoclonal antibody. It targets a receptor on the giant cell and it neutralizes it, okay? Bisphosphonates work much in the same way, and that osteoclasts don't like to reabsorb or remodel bone that has bisphosphonates deposited in it. It's almost like a toxic poison for them. And so you don't get as much remodeling, so you don't get as much bone reabsorption. So what little bone increase anabolic function you have for making new bone has a net increase. So you tip the scales, like in the last lecture I showed you, to more bone production and less bone reabsorption. Okay, so it's a rank L inhibitor, been shown to increase bone volume by decreasing reabsorption. Okay, but late it's been found also to actually be a little anabolic and actually make some bone. And you can see that on the right. After 36 months, BMD has increased 9.2%. Bone mineral density. The density of the bone got better. Then the next thing that came along was basically PTH analogs, teriparatide specifically, okay, but PTH analogs, and there's several of them out there now. And basically, these were done in Japan because, again, of the reasons I explained earlier. And when they gave these people and they checked the metabolites of bone production, basically which are these chemicals called P1NP, don't have to remember this, but you can check in the urine to see what the bone turnover is. And what they showed was that they increased bone turnover. In other words, they were anabolic, which is a marker of making more dense bone, which will prevent fractures and help the osteoporosis that exists. So these were widely given in patients that were having surgery, and they measured these tracers. Okay, and what they found basically was weekly teriparatide promotes bone formation at the surgical fusion site as indicated by these bone markers. In other words, we were making more bone in these patients to cut down on the postoperative failure of the instrumentation or failure to fuse or all the other complications we were seeing. Really, this was done just less than a decade ago now. Okay, and many other studies, this one by Otura, who did a bunch of marvelous studies, and what he really looked at, he really compared oral bisphosphonates to teriparatide. So now we're comparing different kinds of bone building drugs that we actively use, and it's important to know about these things. And what they really found was that the teriparatides group did better over the bisphosphonates. In other words, bisphosphonates just slowed the loss of bone, so you had a net, you didn't lose it as quickly, you did not build bone. Well, teriparatides actually went in and affected the metabolism of the bone and made you produce more good bone tissue to strengthen the bone, as we showed earlier. Really landmark things we found. So Otura comes along, Yagi comes along, Abada comes along, and basically we know teriparatide improves fusion. It has a positive bone effect on healing. In these studies with people that had surgery, 10% a year, the outcomes were about the same, and they felt that the complications that we showed earlier that you'd have if you had poor bone after spine surgery were better. So the Oturi triad of papers, okay, the first one shows the teriparatides, okay, PTH analogs. In other words, these are chemicals we'll talk about that mimic the effect of parathyroid hormone without some of the negative side effects of bone reabsorption and kidney remodeling or kidney ratio disturbances and things along that line. Then he looked at fusions, and teriparatides clearly increased the success of fusions by a significant amount, okay? And finally, he looked at teriparatides versus bisphosphonates, and they work simply better. The injectables work better because they're anabolic and build bone. So we keep going on, and we're seeing it given after a year if it increased bone density. And what they found was that, again, in this particular study that was done by the European Spine Society in 2023, everybody's repeating everything over and over again to prove it because we need to get a consensus. The study showed that PTH analogs, in other words, drugs that mimic the effect of parathyroid hormone on the bone as far as building bone mass, okay, were a very powerful adjunct to increasing bone density. In other words, they worked, okay? And so this is another study done in a different continent than what we saw coming out of the Asian market where this was so prevalent. Osteoporosis is so common in those countries. Okay, so here's another global spine journal with a respective cohort study of osteoporotic-related complications. All these patients had long fusions. They basically were treated with medications, and what they found was the authors concluded that no treatment osteoporotic-related complications, 15% had no treatment, while the 66% of the osteoporotic ones, and 32% suffered a new vertebral pathological fracture, and about 20% underwent surgery. Okay, and what they wanted to point out was that only out of 849 patients, only 121 were treated for osteoporosis. So it's no surprise that this study showed that the bottom line was that the patients that weren't treated had some pretty bad spine surgery outcomes. Okay, so this is a wake-up call when we saw this come out. Okay, pretty much what we talked about. So when we looked at the last lecture, we talked about Hounsfield units and how we identify osteoporosis and how important that is with that or a DEXA score. And so when we looked at our Hounsfield units, which remember I talked to you, we always have available because most of the time we'll do CAT scans on our spine patients for anatomical positioning of the screws and a lot of other things we look at. But we can check the bone density. And we found that people that had low Hounsfield units, remember I told you anything less than about 110 was bad? Well, the threshold on the right, they measured people at that level and below, and look, pedicle screws came loose, cages between the vertebrae came loose, they fractured above because this is stiff and this is soft bone above. They got other fractures in the hip or whatever. So a lot of complications, and you can see how the screws loosen up on these patients on the picture on the top right-hand side. So we're finding out in the spine that we can't operate on a lot of these patients because their bone is so bad, okay? It's even worse than that. This is a study out of Vanderbilt that Dr. Vickery, who was one of my fellows last year, was a terrific fellow, a very smart guy, worked on this paper for everybody. And they looked at CAT scans on people that had long fusions for adult curvatures, adult deformity, we call it adult spinal deformity, that develop pinched nerves and things that had to be operated on because it's so terrible to have, when you had sciatica, it's miserable to live with. You just can't, even when you sit, it's just, you want to, really, it's unbearable. And they were operated on, and they tried to make sure the bone was okay, but what they found was the mean Hounsfield unit was 153. Well, that's really at the upper end of getting to pretty much normal above 150. And even so, they came out and said the Hounsfield units would be 163. Well, that's far above 110 that we've been talking about the threshold for osteoporosis. So whatever adults are simply different than doing pediatric surgery for scoliosis. It's an entirely different ballgame because basically the bone health. So you can see here that really for large curves, you've got to pre-treat these people and get their Hounsfield units way up high before you operate on them, and that's going to take time. And that's going to take our involvement and, of course, our primary care colleagues. So we'll talk about medications now. Very complicated. I'm just going to be cursory about this. You'll have to actually go to the PDR and look up the doses because it's hard to remember these things. Remember how I showed you this earlier in the diagnosis? Look at all the people and the different populations that are vitamin D deficient. And over a lifetime, which they have not been able to check with the vital study that we'll talk about, where it says you shouldn't take it if you're normal, but they're not looking at people in coastal Africa who have vitamin D levels of 15 for their entire life and never develop a strong, robust skeleton like a lot of people do. And so it's epidemic around the world having low vitamin D levels. First thing you want to treat, okay? Also, these are the things you can look at. I mean, daily calcium, we've talked about the levels, 1.2 grams of citracal. Citracal is better absorbed in the gut, it's not absorbed in the stomach, and calcium carbonate is, and people take, it's an antacid, and when you have not a low stomach acid level, it's not very well absorbed. That's why we give them calcium citrate that's absorbed down the gut and the duodenum better, and that's preferred, and that's the average of this table. And of course, the vitamin D is also available, D2, is available with all these things. I like the shiitake mushrooms or the sun-dried shiitake mushrooms. You can get a lot of vitamin D if you want to eat that every day, but I think a pill might be a little bit better for your patients. So vitamin D treatment for surgery, some people recommend superdosing. You can get it above, if you give 1,000 IUs, that'll keep it above 30. 5,000 if you want to get it up back to normal for 5 months, or even preoperatively, they're giving 600,000 units preoperatively to get them back up to normal levels. So you can also superdose these patients preoperatively if you're doing an emergency patient, for example, as you see here. So we're going to talk about the specific medications more and advances over the last 2 decades. Baseline treatment, okay? Vitamin D, calcium, okay? You want to make sure they don't have any risk factors: smoking, steroid use, tumor necrosis factor use, liver disease, alcoholism, all these things. Remember that when we talk about physiology, we'll have a lecture on physiology, that vitamin D is made in the skin, okay, by sunlight, 20 minutes over 4 inches or whatever. And from there, it goes into circulation to the liver, where it's hydroxylated to D2. And from there, it's carried by proteins that carry vitamin D, which may be deficient, by the way, and cause vitamin D deficiency, just genetically, to the kidney, okay, where it's hydroxylated again, because it's 125 deoxycholinesterase, and that's the active metabolite. So if you have a bad liver or a bad kidney, you're in trouble. Okay, so renal patients, they can't make D3. They have to be supplemented. And so keep in mind that you have to replace all those things first. Lose weight. Exercise keeps bone from losing bone mass. Okay, weightlifters have stronger bones because they lift more weight. Okay, and then you proceed with these medications after we do the testing with the 3 methodologies, right? FRAX scoring, DEXA TBS, or the CT Hounslow units. Now, once we've established they've got osteoporosis, particularly if it's minus 2.5 or greater, and they've had a pathological fracture in particular, we can proceed with some of these medications. So bisphosphonates came around in the 90s, okay? You all know about those. They cause a lot of heartburn, a lot of reflux. They got to be taken very phoenically. A lot of people bypass that by doing IV every 6 months or once a year, zoledronic acid. SERMs are estrogen modifiers. There's really only one of these on the market, and needless to say, all of us males, of which are 20% of the osteoporotic population after 70, we're left out in the cold, and that is revisited again. Denosumab, which has been around for about 15 years, which is, has its own unique benefits, but also downside in that once you start it for more than 2 or 3 years, you cannot stop it for the rest of the patient's life. Because when you do, you get a massive rebound effect. The PTH analogs that you can see, teriparatide and abaloparatide, and of course romosozumab, which is the newest one, which again was only tested in females. There is a male test, it works fine in men, but they only tested in females, I think, in a rush to market. And we'll talk about it, but there is a male test going on, a series going on right now. So pay attention to this because there'll be a test on this. I'm just kidding. You can make bone or lose bone. Catabolic, you lose bone, or anabolic, you make bone. So you can slow down the loss or improve the production. So when you look at this at a microscopic level, okay, when you look at the anabolic, we want to stimulate osteoprogenitor cells, pre-osteoblasts to osteoblasts to make bone. Okay, so basically, when you look at this, the PTH, all those cells have parathyroid hormone receptors. So that's how parathyroid works. So these parathyroid analogs stimulate the osteoprogenitor cells to make more bone. Okay, and so we have several of those now that are available. So the teriparatides come in here and they stimulate the osteoblasts to make new bone. Okay, now sclerostin, which we'll talk about, is a masterful Sherlock Holmes mystery that they solved. And romosozumab blocks the sclerostin molecule, and that also turns on osteoblasts to make more bone. So those are the 3 anabolic medications. Now on the other side, to slow bone loss in somebody that's got a T-score of minus 1.5 or 2, you would basically block these and you give the bisphosphonates. And it binds to the osteoclasts, which resorb the bone, okay? And what it really does is it gets deposited, and they don't like to form a ruffle border to dissolve your bone, to remodel it. Because bone is always remodeling, it's always making and deleting new bone. Your entire life, you replace your skeleton every decade. Okay, it just slows down as you get older. Okay, so that's how bisphosphonates works, and denosumab binds to the osteoclasts and neutralizes them directly and prevents them from doing the bone. This is how everything works. This diagram tells you everything that's going on. And these are the medications that are available: bisphosphonates, PTH analogs, estrogen blockers, and modifiers. Now, one thing that's happened just recently, I must mention, is that for years and years, estrogen wasn't recommended postmenopausally. Well, that was in my generation with a lot of people I'm sure that many of you know. It was based on probably one study that may not have been quite as accurate from what I've read. And we'll check this out further, kind of like a podcast here. and bring you the results. But a lot of women, we did not see this kind of osteoporosis in women with the last generation. But we're seeing a lot in my generation. And none of my generation were started on postmenopausal estrogen, which definitely gives you a loss of bone. So Premarin and those things were used quite commonly, and it probably was a little bit osteoprotective. So now, of course, I do believe they came out just recently, a week or two ago, and said that they recommend giving estrogen again. It's kind of like the margarine butter kind of thing, you know, where one study said butter was bad, which doesn't make a lot of sense considering we've been eating butter for, what, maybe 300,000 years since we domesticated animals. So it turns out that a synthetically produced oil was better for your heart, not necessarily. So we have to be careful and really analyze what these papers say. Anyway, and then of course calcitonin can be used nasally for short-term use. It's kind of nice for minimal vertebral fractures for a couple weeks. It makes your pain go away quicker, but it loses effectiveness and cannot be used long-term after 6 months, so it's limited as far as its usage. And of course denosumab and rosumab we talked about. Oral bisphosphonates, they're anti-reabsorptants. They'll increase your bone density 5 to 10%, okay? You have to take them and sit upright because they cause terrible erosive esophagitis, and take them on an empty stomach, okay? You get osteonecrosis of the jaw. You can tell your patients that it's only 3 to 10 per 100,000. It's really rare and it's associated with long-term use. Why? Because your jaw is constantly remodeling. It's kind of a rough environment, okay? So it's constantly remodeling around the base of the tooth, and and basically oral bisphosphonates stop that remodeling, okay? And what happens is you don't produce any new bone and the teeth get loose. And that really scares your patients because it's all over the internet. So you have to sit down and explain that to them. It's relatively rare, and I'll show you how we can treat it. So alendronate is one of them, 10 milligrams commonly, or risdronate. Risdronate is the other one, 5 milligrams QD. And you take it daily, and you also can take it weekly. And it works pretty well, but it's for milder cases. It does not build bone. You can also give IV zoledronic acid. We use this a lot as a follow-up treatment after we've had people on anabolics like the PTH analogs and romosozumab. And when you first have it, I just want to let you know that the patients will get kind of achy and really sore for about a day or two. So not everybody, but just some of them. And so you have to tell them to expect that and give them something for that. You can have sometimes some serious reactions to it, but if you've never had a bisphosphonate before, you got more of a chance of that. And it rarely causes osteonecrosis also at about the same rate that orals will. If they're and you do these for 3 or 4 years, and then you give them a drug holiday to let the bone remodel a little bit, so you don't get really brittle bone and the femur fracture associated with it. So if you want to treat this, okay, that osteonecrosis, particularly the jaw, you can put them on a PTH analog, and there's a couple of papers that show that you can actually, as you see here, heal them in. So you can tell if we do get it, we got a treatment for it now, which makes sense. Now we're going to build bone instead of slow down the reabsorption, so you can get an active environment in there where you basically can regrow normal bone. Denosumab, you can actually have an increase about 10 to 15% a year on a little bit more than bisphosphonates, but about the same. We talked about it blocks the RANKL inhibitor, surface antigen receptor rather on the osteoclasts, and they just stop dividing. And they actually stop forming osteoclasts, and then you don't reabsorb your bone, so you get a net increase in bone. Okay, but again, remember that with time, it'll actually become a little bit anabolic also. It's common side effects, back pain, extremity pain. Similar osteonecrosis in the jaw. Remember, you can get the same problem with this, it's just not as well publicized as you do with the bisphosphonates. The thing I need to really emphasize to you is when you stop it, you got to replace it with something, and you have a limited options for this, okay? Results in increased bone loss within 3 or 4 months, and you'll return to where you started. So you get a rebound effect with stopping denosumab, and you can. And I've seen one patient that I've got a good example of that basically broke a bunch of vertebrae, okay, and was just cold turkey stopped it. It was stopped. So you have to really recommend stay on denosumab once you're on it, pretty much forever. After 2 years, which is the recovery time, you might start one of the other ones, and I'll show you why. You have to just stay on it, okay? And here's a good study that you can look at if you want to. You can go back and pull the reference off. And really, this guy, Lee wrote just a wonderful article. 10 years gains, the bone mineral density is 20% in the spine and 10% of the hip. So it is somewhat anabolic. And it's safe, It can be continued indefinitely with chronic disease states. It's supported by multiple studies, and even with myeloma, it is also beneficial to fill in the lesion. So teriparatide was tried to reverse the effects of denosumab. You say, well, why don't you just give them an antibiotic? It doesn't work for whatever reason. Denosumab was given for 2 years, and it showed no improvement of BMD. And the only thing you can really give somebody that's been on denosumab is probably bisphosphonates. Specifically, just give them some zoledronic acid. So once you've been on this, you can't use the anabolic ones. So keep that in mind. So somebody that's got a minus 2.8 DEXA score, you want to put them on an anabolic first, and then probably follow them with zoledronic acid after 18 months when you finish the course of a PTH analog. You don't want to start somebody that's really bad because it doesn't build enough bone for them that we can do surgery. These are for people that probably have, I would think, a minus 2, and you just want to put them on some. Keeping in mind, you may need to keep them on them forever. Very, very important. The PTH analogs, as you can see, increase BMD 20 to 30%. Common side effects are aches and pains of your bone. It did have a black box for osteosarcoma, but that's been removed because we've never seen anybody with osteosarcoma. It just caused in the test rats, which, by the way, they give it at 10,000 times the clinical dose that you would give somebody, hopefully. And the teriparatide, there's a generic available of it now, and the abaloparatide is also safe. It's a little bit better because it doesn't affect the kidney as much, and it's safer for the kidney with people with renal disease. So that's the one that we tend to use the most frequently on our patients. Okay, romosozumab is the final new one that came out about 5-6 years ago, widely available. It's a 20 to 30% increase. It's a little bit more powerful and works a little bit more quickly. It's a monoclonal antibody that blocks sclerostin. So sclerosterosis, okay, if anybody can think about what that is, it's a rare diagnosis. It's a genetic disease we'll talk about just briefly, maybe because it's just interesting. Add a little color to this talk, which can get a little dry when we talk about medications. The common side effect is arthralgias from it. Now, here's the problem with it. In 2 of the 3 studies, it had a slight bump in cardiovascular risk, including strokes and myocardial infarctions. So there's an increased risk of those and some death. Okay. Now, there's a Japanese study that did exactly the same thing. It shows no difference between the controls and the people on the drug. Keep in mind, it's a different population that's in the United States, different genetics and everything else, so it may not affect them, but it may affect us. So you should always ask the people if they've had a cardiac event within the previous year, and if they have, you probably should use one of the parathyroid analogs, okay? So that's something to remember that you probably, and people look this up online, so they're going to ask you about it anyway, so you don't have to worry about it. Now, sclerostosis is a rare genetic disease caused by deficiency of the gene that codes for sclerostin, resulting in very high bone mass. Sclerostin blocks bone production, and it's produced it's a feedback loop. So people at a company said, what if we make an antibody against that and block it? Let's see what happens with bone density. And sure enough, in test animals, when they put that antibody into those animals, their bone density increased. Because by blocking an intercellular pathway, it made more osteoblastic cell production, which resulted in anabolic bone production, which resulted in increased bone mass. So then it went through all the trials in humans, and it's really amazing. But anyway, these people, I'll show you a picture of them here. They produce so much bone. They're much like osteoporosis, if you know what that is, marble bone disease. And it causes all these, it's an autosomal recessive, it runs in families, and they just make bone. Their T-scores are plus 15, okay? And this is what it looks like. So you can see their calvarium gets thicker. Their DEXA score is 14.5. Their bone is incredibly dense because all they do is make bone because sclerostin is a feedback protein that slows down bone production. So what a wonderful thing. Okay, so here's our little Sherlock Holmes here. We're going to work on stuff. And they tried it in animals, and there's a protein called BMP that we use in surgery that kicks on the BMP pathway, that kicks on osteoblasts to produce a fusion and cause bone healing. Just another pathway. It turns out that the PTH receptor, where the PTH analogs hook to, and we'll talk about this in the physiology, and okay, the BMP bind very close together, and they work synergistically to make a fusion and bone healing occur more quickly and more reliably. So they both kind of push you toward bone healing and bone improvement of the bone quality and bone density. And sure enough, when we use them both in a rat model, you got much more robust on the right at the bottom than not only. Look at the defect. You just basically munched out a bunch of the femur, and then you put those proteins in there. And if you use BMP alone, it didn't do as good. But boy, when you put BMP and the Avenity I'm sorry, not Evenity, romosozumab, when you put that in there, you get a much more robust fusion. And what it showed was BMP combined with a teriparatide or these anabolic medications, you get better bone formation. That's important for us because we want the patients to fuse. And pretty much that's what this study showed. So here's a picture. We'll show you another little diagram here of how BMP works. Here's a cell. It's a little bone cell sitting there in your bone. And you have WNT, which is a stimulating protein to bone production. And you have sclerostin, which inhibits bone production. So basically what happens is when you have sclerostin, okay, it binds to the cell if it's produced in large enough quantities, and it shuts down bone production for whatever reason, like you're not exercising as much. And the beta-catenin basically does not get produced, which is what stimulates the nucleus to make more bone cells, to make more bone, so you end up with weaker bone. So let's just sit here and think, well, what are we going to do now? Okay, so this time we're going to have the sclerostin floating around, and we're going to put in that antibody we made. This is just marvelous engineering. And it allows WNT to go ahead and attach to that one receptor, which kicks on the beta-catenin, which kicks on gene reproduction in the nucleus, which reproduces more cells, which makes more bone, which makes better bone. That's exactly how it works. A very simple kind of way to do it. Very elegant chemistry, biochemistry, so to speak. But that's how sclerostin works, that they were able to figure this out. So when we look at romosozumab as it works, which is a sclerostin blocker, you can look at the top bar, every one of those graphs, and you can see that when it's given for 12 months and 24 months, it makes more bone, a lot of it. It does not work much more. It works for 12 months and then that's it. Giving 24 months was found not to be that effective. And when you look at this in postmenopausal women, on the left there you can see the incidence of fractures given. The fractures when you gave this was dramatically decreased. And when you look on the right, the transition is what we would do is we take them off the romosozumab and we put them on a little bit of denosumab, and basically their bone got even stronger. So we build bone, and then we'll give them a zoledronic acid reclass, and that'll keep them from resorbing bone. And then we'll build more bone, maybe with a teriparatide, and then we'll slow down the resorption. So you see, we build, slow down reabsorption, we build. So we cyclically use these medications now over the course of a decade, perhaps. And they also, in some instances, are used together for very severe patients. So really marvelous kind of thing. So this is what I really wanted to show you. When we looked at the Hounsfield units, and this is the graph that I wanted to show you, is you can see that what we're looking at here is we're comparing the teriparatides to romosozumab, which are the two anabolic medications, okay? And what we show you is that the romosozumab works much faster. So we can actually build bone within 3 or 4 months significantly, up to 25 to 30%, which seems to be enough to keep us from getting fractures during surgery. Why is that important? If we use a teriparatide, in the end, at a year, they're both the same. But we've got a patient here that's got bad spinal stenosis, that can't walk, he's getting weak, that we've got to operate on. So that is probably our preferential drug to build bone as fast as possible to get their surgical problem addressed, rather than waiting to the teriparatide to work over a year to get the same amount of bone density. They'll both be equal. Why? The problem is the insurance companies. Is a lot of times they won't pay for the romosozumab because it's more expensive, or they want to try something else. But it does work better, and it does work more quickly, and we're measuring the Hounsfield units because we have the CAT scans available in our spine patients. We're not repeating the DEXA scans, which can only be done 2 years. So romosozumab, due to its shorter duration to achieve similar to teriparatide, may be the preferred treatment in our preoperative spine patients. So real quick about the cardiovascular things, here's what it shows. It inhibits a pathway, and it basically, you can look here, you can see there's a slightly higher incidence of myocardial infarction, a slightly higher incidence of strokes when you compare it in 2 out of the 3 studies, the romosozumab to the bisphosphonates. Okay, and so that's what you worry about. The patients will know about this. If they haven't had any incidents within a year, it's okay to use it, but that's really what they recommend with it. There's a little bit of caveat to that. So it's very powerful, romosozumab. You only give it for 12 months. They are doing studies currently where you may be able to repeat it after 2 or 3 years, for example, reclassed IV to slow down the resorption of the bone you've built. It is not approved for men, but my understanding is that it is being tried in men now. And you have to weigh whether the fracture risk outweighs the cardiovascular risk. If you got someone with a T-score of -40 and they're going to break their hip, it may be worthwhile to do it if they have minimal cardiac disease. So just keep that in mind when you do it. So I'm going to show you what happens in real terms when we do one of these patients that's osteoporotic. Here's a patient that comes in, and basically why pay attention to this BMD and treat them ahead of time. So when we look at it, look at the Hounsfield units. You may not be able to see them, but L2 is 82, L3 is 52, L4 is 80, and L5 is 77. Well, that's dramatically below the threshold of 110, right? And it's approaching 50, no surgery. So this would equate to a DEXA score of minus 3.0, which you all know is pretty critically low. So this patient was taken to surgery with these kind of readings, okay? And you can imagine the reason was the patient had terrible spinal stenosis and leg pain and wanted surgery, and that will influence our decision. The surgery was relatively unremarkable. We had a little bit of trouble with screw placement, but what happened? This is what happens literally 2 or 3 days after surgery. You can look at the post-op films and see that right at the top of the instrumentation, I pointed out for you there, basically right in this area here, this is all fractured completely through here, and this is slid backwards and it's pinching the nerves, and these screws are pulled out. There's been a catastrophic failure of the bone architecture in here that's resulted in the patient's entire upper spine tipping forward. This is a bad problem. And you can see here that there's a fracture and the screws are pulled out and the canal's okay, but right here across the pedicle, you don't need to know this, but it's broken. Just say the vertebral body broke, the screws came loose, the patient. So we had to take the patient back to surgery and extend the patient up, and the patient was immediately started in the hospital on a PTH analog to try to build the bone, which actually will work. Within 2 or 3 weeks, it actually will stabilize the bone. So you can do sequentially and combined therapy, but again, these are the first-line drugs are generally the bisphosphonates, calcitonin, and the SERMs on women. The denosumab is really a second-tier drug for, in my opinion, the osteopenic patients, keeping in mind that you may have to keep them on it once you go beyond 2 years forever. And of course, for the patients that have really bad, that need surgical intervention, we recommend the other ones. So why do we know? So we talked to all the surgeons across the United States. And guidelines, these were done by Zishan Sandar, who I know very well. He's at Columbia. I was part of this study, but you can't see me because I'm way down here in the middle right there. But I did participate in it. And what we looked at was how do we prophylax patients before spine surgery? What do we use? Okay? And so we looked at all these risk factors that we've talked about: alcohol use, vitamin D deficiency, smokers, obesity, kidney disease. Okay, we assessed them and then we did treatment. And the treatment basically was teriparatide or abaloparatide, the anabolic ones that build bone, okay, anti-reabsorptive agents if they couldn't take the anabolics, okay, and vitamin D and normal calcium intake. And what it really showed is that the preferred drug was always pre-treat them and use the anabolics. Now this is a paper that I wrote with the Congress of Neurosurgeons with all these other great neurosurgeons that I worked with, and we actually did guidelines. We actually reviewed all the available literature and looked at what people were recommending at the time. And we asked 3 or 4 basic questions. What preoperative diagnostic studies to predict the risk of osteoporosis? And these are guidelines now. To prevent adverse effects after surgery, okay? And what we recommended was that you get a DEXA scan or a CAT scan Hounsfield units, you get a D3 level and a calcium level, okay? And you should assess all the patients with these. And the level of evidence was grade B, which is quite high. You rarely get grade A. And that's from looking through about 600 papers, okay? And then weeding them down to the best papers you see below. So you should always do that before spine surgery. This was done 4 years ago, actually 5 years ago, and people still ignore it. Does preoperative treatment of low mineral density risk preoperative adverse events after surgery? Absolutely, absolutely, as I've showed you. Consider preoperative teriparatide in patients with osteoporosis. This was right when romosozumab was being released. And because it's an anabolic, the suggestion was for people with bad bone, grade B again, that you give them a teriparatide, a parathyroid analog, preoperatively to prevent. There wasn't enough evidence to say whether bisphosphonates worked or not. There just wasn't enough. So the latest recommendation by Paul Anderson, who's kind of the godfather of bone health, and actually, if you look at the other lecture, the American Orthopedic Association, he kind of was head of the Own the Bone initiative. When you look at everything, this is pretty much the criteria that we've already talked about in diagnosis. Normal, osteopenia, osteoporosis, high risk, severe osteoporosis, very high risk. Pretty much what we've talked about. and how long you're going to delay. So you can see with severe osteoporosis before surgery, you're going to wait 9 months with pre-treatment before you operate on them. So just a nice little algorithm you can look at. If they're high risk, you want to get a DEXA scan and a CT ROI. You refer to bone health and you delay surgery until they're optimized. If they're low risk, you still do those testing if you think there's a lot of risk factors, but you can proceed to spine surgery. Everybody should be started on vitamin D and calcium in our opinion, and get those lab tests we've talked about. Now, often it depends on the procedure too. If I'm doing something simple like a laminectomy where I just take away some bone, you can basically operate on them in 3 months after treatment. If you're doing something moderate, like a 2-level or 3-level fusion and they've got osteoporosis, you probably ought to treat them 3 to 6 months. And if you're doing a major adult deformity, like I showed you that failed, you probably ought to treat those people for 6 months to 12 months at the very least, or you're going to have a catastrophic episode. So, surgery in the aging population. The first thing you do is to treat the metabolic bone disease. Surgical modifications you can do, again, just to kind of recap everything. Fusionless technology, you can do something you don't fuse them. You can do a vertebroplasty if it's just a compression fracture. If you do surgery, you're going to have to often do them front and back and do various bone grafting type of materials like bone morphogenetic protein to boost the fusion rate. You have to do iliac fixation and a lot of other stuff that really add to the complexity and cost of the surgery. And the bottom line is, first treat the metabolic disease and you won't have to do a lot of those things. Okay, that's really, really important for it. So to conclude, knowing the physiology of bone, okay, helps make you better choices. You should know what are anabolic and catabolic. We know we want to stimulate the osteoblast to make more bone, whether you're getting surgery or not getting surgery. That's the whole treatment of osteoporosis, is to make better bone, and you have to do something to goose those cells to make better bone. You must treat the underlying bone pathology, okay? They might have myeloma. They might have some other tumor, or they might have sickle cell, or they might have a parathyroid adenoma. You have to do those laboratory tests we talked about to pick that up before you operate on people. And we'll show you cases where we did not do that, okay, and we went in blind, and it makes a difference. You need to know the difference between anabolic and catabolic. The bisphosphonates are basically catabolics. They slow reabsorption, while the teriparatides and rosumab actually build bone, and you should consider pre-treatment with these strong medications here. Teriparatides are better. Ramosuzumab is better. The bisphosphonates you're in a holding pattern. So all patients should have vitamin D, calcium, and be nutritionally optimized. You need to check their total proteins, which we do. Okay. In high-risk osteoporotic patients, you treat with the anabolics. If the patient's score is less than -3 or the Hounsfield units are 50, they should have anabolics and they should not be operated on right away. For simple cases, you can delay 3 months. For more complicated cases, it may be up to a year, and then you have to serially recheck their Hounsfield units or things. So now we'll stop for a second. Everybody can grab their breath, and we'll go through some basic questions that we'll talk about and have a little summary. What we've gone over the last 30, 40 minutes, it seems like it's really specialized knowledge, but you can see there's only a few little things you need to know. If you choose just to screen people, then you know what a DEXA TBS score is, you know what a FRAX score is, very little effort tool that we use, and of course you know that if you've got a CT scan, you can check the HUs. I showed you how to do it on the last lecture. If you choose to go further, well, then you should have all your patients on vitamin D3 and check their levels, and you probably should have them on calcium. And if you want to go a little bit further, you can actually screen and order those lab tests that we talked about, and it's remarkable how many people that you'll find have celiac disease. We've found 5 or 6. How many have myelomas? We found 5 or 6. The significant number of people we've sent for parathyroid adenomas in a couple of years, where their PTH is causing their calcium to be a little high, bump high. How many people you're going to find with vitamin D levels that are in the cellar that never take it or never get out in the sun. And you can choose just to be the gatekeeper and diagnostician. If you choose to really learn it, you can see that there's only 5 drugs or 6 drugs that you really are part of your armamentarium. The catabolic ones, the bisphosphonates, and denosumab, or the anabolic ones, which consist of ramosuzumab, or the PTH analogs, of which is actually some generic now that are half the price of the other ones. And there's many coupons available that the patients can go in and get these for almost nothing. It just takes a little bit of persistence, okay? So you can choose to treat at multiple levels in something that really is pretty well almost worked out now. Keep in mind we will have future changes, of course, that will come out. Most notably, like for example, maybe you'll have to put everybody post-menopause on estrogens replacement. So it's not as difficult in a lot of ways what you think, but we just want to get people thinking about it and doing the testing and then resulting the testing. And we're going to have, hopefully, people within the system that can help out, a core of people that actually will be treating this, that we'll talk about, and the team. And we call that a fracture liaison service that we'll talk about more and have another lecture about how to set that up, which is kind of what we're doing now. So we're going to go ahead and just do some basic questions for CME. The first one is, what is the incidence of osteoporosis in preoperative patients? I made a big deal about this, okay? And the one paper that talked about it, and the answer, of course, is C. It's not 10 or 30%, it's not 80 or 100% of them don't have it, but about 50% of them do on average. And so they either have osteoporosis, okay, or they'll have some of the other things, maybe osteomalacia, or they'll just be osteopenic. But it's worth finding out and knowing that a lot of our patients that are sent to us for surgery of their spine are not operative candidates because of this until we get them tuned up. So patients will have poor bone health. Poor rates often show 10 to 38% are osteoporotic, 30 to 59% are osteopenic, and only 19 to 51%, depending on the study, have normal B&D. And depending on what kind of spine surgery patients you operate on, a disc or just a single level fusion, your patients are going to look great. But at our center, where we have to take care of everybody from A to Z, where we got a lot of really sick patients that are ICU candidates, it's going to be much, much higher in those patients. Question 2. Ravanda, the author, showed the time to fusion is dependent on vitamin D3 levels. How do low levels less than 20 nanograms per deciliter affect fusion rates? Do they have no effect? Do they speed up the fusion rate? Have a variable effect depending on age, or significantly delay fusion rates? All the studies showed that low vitamin D levels less than 20 average 12 months for fusion, while those greater than 30 average 6 months. So vitamin D levels are important. Question 3. Mazurki showed that low vitamin D levels cause more post-op complications and lower spine fusion rates. Is that true or false? Well, the answer is clearly true. The study showed that osteoporotic patients have a 50% post-operative complication rate, half the patients, and a 48 incidence of failure to fuse. In other words, you've got a 50% failure of your surgery, which means it's most likely unsuccessful. Really something that should not be allowed to happen, that half your surgeries fail. We would never accept that if we were taking gallbladders out or doing appendectomies, okay? Question 4, which osteoporotic medication are primarily anabolic? Well, we've talked about that a lot, okay? Is it bisphosphonates? Is it zoledronic acid? Is it the SERM or the estrogen blockers? Is it denosumab or is it teriparatide? The answer is E. Parathyroid analogs and denosumab are anabolic, build bone. Denosumab is slightly anabolic with prolonged use, but 10 years. And bisphosphonates are catabolic and just slow bone loss. Question 5. Which anabolic medications work fastest to build bone but carries an increased risk of cardiac events, such as MIs or cardiovascular events? Is it alabaloparatide, one of the parathyroid analogs, teriparatide, another one, or romosozumab? Well, it's C. Romosozumab in 2 studies showed a slight increase in cardiac events, which warrants patient disclosure, but achieved faster increases in CT Hounsfield units at 3 months for osteoporosis compared to the PTH analogs. So you just have to tell your patients about it, make sure that they haven't had a cardiac event in the last year, and then generally it's safe to use. But the patients are pretty savvy. They look these drugs up online and they'll come back to you and ask you what the complications are. Final question, question 6. How long should elective adult major spine surgery be delayed for osteoporosis and anabolic treatment instituted prior to corrective surgery? Is it okay to operate on immediately? Well, I'll give you a hint. We showed you a case that wasn't a good idea. 2 months, 4 months, 6 to 12 months, or all adult deformity non-operative, just let the patient suffer. Well, we could do that in 1900, but we can't do that now. We've had discussions about that. Generally, we like to treat our patients and make their life better, and we can do that. So the answer is D. Most experts recommend 6 to 12 months preoperative antibiotic treatment for adult deformity with osteoporosis prior to corrective surgery. So if they're diagnosed early and treated early in for example, a primary care doctor's or provider's office, and they come in 6 months into this, well, we're way far ahead of when they walk through our door just sent to us because they've got back pain. And so that's why everybody should be screened if there's any consideration for the need for spine surgery, because it's important that if we don't do that, they're going to fail a lot of times. So in summary, I've tried to go over the high points of what the studies show of what we face in spine surgery and how dramatically it affects not just spine surgery, but probably fixing a broken hip or rotting a femur or fixing a broken tibia or any number of fractures that occur. A lot of people with osteoporosis get foot fractures that just never heal. You see that in diabetics a lot, but is it due to that or in combination with being osteoporotic and having poor bone that allows them not to heal? And it's really a combination, additive effect, because we didn't bother to check their DEXA scores. And so this is what we really want to highlight, the fact that bone health doesn't just affect us. It affects any bone surgeon that's doing any sort of corrective procedure. So that's why we showed all those, to give you some sort of idea that there is strong evidence to show that. The medications are a little bit more complicated. They take a little bit of practice to do, but they're using these medications is very attainable. Designate one of your, if you're too busy, we have going on 3 nurse practitioners that treat this now, and they are wonderful. They're smarter about it than I am, certainly from the treatment standpoint, because they use these medications every day. And it takes a little bit of practice and understand a few of the complications of them, because there's not a wide repertoire of these like there is with high blood pressure medications where you got 50 different things you can use. It's a pretty specific, laid out kind of idea of how we treat this now. But just keep in mind that once you get good at it, that the treatment should be lifelong and it should be sequential with alternating these various medications over the decades. So I hope you enjoy this lecture. We're always available to answer any questions. And of course you can take these, also get some CME out of it. It may be in a little bit different format that you have to take independently at the end of the discussion. Thank you for listening.